But we're going to talk about spine surgery. I know it's kind of depressing, and it is. There's some scary x-rays we're going to see, and some interesting statistics from people like Johns Hopkins University, which I thought was interesting. So, common conditions that are usually treated, or sometimes treated, because hopefully they go to non-invasive chiropractors for scoliosis, for sciatica, neck, arm numbness, that kind of stuff. But a lot of times, sadly, they end up going to get surgery. And here are some of the risks of surgery. So you can have a reaction to anesthesia, bleeding, infections. I have a really good friend of mine that actually had excessive scarring, and this is what I hear all the time. People come in, they say, I've got the sciatica, it's killing me, I got to get it fixed. I say, okay, well come on in. It's going to take a certain number of adjustments, and you have to really stick to the schedule and do the changes that we tell you to make, and don't do the things we tell you not to do, and that kind of stuff. And he came in for a couple of visits, and he's like, you know what, it's bothering me too much, I just want it fixed now. And so in his mind, having it fixed meant he was going to go have surgery. So unfortunately, he went and had surgery, and he had excessive scarring. And that's one of the worst things that can happen. Well, not one of the worst things, but that's a really bad thing to happen when you have surgery, because the only way to go in and take the scarring out is to do more surgery, which means you're going to have more scarring. So now he's just out of luck. So that he's just loaded up on meds now, because that's the only way he can keep going, and it's just really depressing for him and for us. Stroke, heart attack, blood clots are always a big problem. And here are some types of different surgeries you can get. Spinal fusion, that's when, and this was the craziest thing to me when I was doing this research. Okay, in the office here, we always talk about how motion is key to have healthy joints. So you always want to have, you have the neck here, you want to do your neck curve exercise, keeping that motion, keeps all the fluids in there, keeps it nice and healthy. And in the low back, you do the arching, the cobra, where you're like this. Ralph, you know this one? Yeah. Where you're arching your, well, not quite arching it that much, but you're arching your back, and that helps pull the disc away from the nerve. But in the medical world, and they're kind of starting to understand that this isn't really a good thing, they feel like everybody's disc gets degenerated as you get older. And a lot of us have been told that our whole lives. And so you're just like, oh, I'm getting older. Does not have to be the case. We see it all the time here. We have people in their 70s and 80s that have spines that look like they're in their 20s and 30s. So you just have to give the proper motion, proper hydration, the adjustments, that kind of stuff. But their whole theory is, these are all going to start compressing, and when they compress, it's going to put pressure on these nerves. And they literally said in some of the research that it doesn't compress fast enough. If it compressed totally and would fuse there, then there'd be no more motion, so then you wouldn't have any pinch on the nerve. And I'm just like, huh? I'm like, that makes no sense at all. That doesn't make any sense. But now they're starting to go in, and we're going to see some different examples in a minute. They're starting to put artificial discs in and things like that to keep the space open. But whenever you incorporate or use a foreign object, any kind of substance in the body, it's going to have bad side effects, and we're going to talk about that in a minute. So they thought fused is good, not moving is good. And they were like, if that bothers you when you do that, basically it's the Rodney Dangerfield thing. Oh, it hurts when I move my arm. Like, well, then don't move your arm like that. So they just tried to fuse it. And that's not good. Laminectomy, this is scary. So the back parts of the spine here, you've got, this is the spinous process here, and these are the lamina here. And what they do is they come in, take this part out, and then they put these screws in to the vertebral bodies here, and then a rod in here. So there's no lamina here, thinking, oh, it's going to take the pressure off the nerves. But it also exposes the spinal cord and the nerves here. But then they have the rods there, and that helps stabilize the section, which is good, but why take that out in the first place? And this is just one of several different scary things we're going to talk about. And here's an example of what that looks like. And this is a horrible story I'll talk about in a minute. This poor lady, this did not have to happen, but she listened to her doctor, and he said, this will fix it, this will take care of it once and for all, and it didn't. This next one's a mouthful. A foraminotomy. Now, a foraminotomy is when they go in, and these are the foramen here, the little hole, the nerve holes basically is what we call them, where the nerves come out. And so they go in and they try to trim some of the bone away to make the hole bigger so there's no pressure on the nerves. But when you do that, it makes the spine unstable, and instability is also a problem, because then it's hypermobile and it's moving around like this section here, it's going like this, and that's not going to be good either. So a foraminotomy, it was like supercalifragilistic. I'm like, okay. But that, yeah, and the scary thing is with things like this, to make it more stable, they incorporate it into other surgeries. So you go in not just for one, you end up getting 1, 2, or 3 surgeries just to help stabilize this one section. And it's like, why don't you just not take that out in the first place and do a non-invasive approach and try to do that first? But they're just not willing to work with us at least yet. Maybe they'll be a little more understanding and realize that we're a pretty good solution. A discectomy, this is when they go in and take the disc out. They can go in, they can take the entire disc out, or if you have a herniated disc, they can actually go in and just clip a piece of the disc out and think, oh, okay, well then it's not going to press on the nerve. But the pressure is still there, and so it's just going to regenerate and force that other remaining part of the disc back to press on the nerve, so it's not going to help anything. Now here is the disc replacement. These are fancy schmancy. There's all kinds of like Teflon, like bionic discs. You put them in there and you're like, oh, I'm super strong now and I can do all this. No, anytime you put any foreign object, like I said, it can actually come loose and get dislodged, and that's a serious problem. You don't want things floating around in your spine that's going to put pressure on those nerves. And here's an example. And this, unfortunately, is that same lady I was looking at earlier. This, so right here, these little spots here, that's the artificial disc. And then there's one there, you can see from the side. That's from the side, this is from straight on, and then she has the fusion, the laminectomy with the screws and the bolts stabilizing this section here. So how can you see that and think, oh, okay, that looks comfortable, I'm going to be a lot better. But the sad thing is people are in so much pain and they take advantage of that. I don't know if they intentionally take advantage. I choose to believe that people are mostly good and they think that they can really help them, but the statistics, percentage-wise, they're not helping them. And a lot of the times, like I said, like my friend, he was not any better, and now he's just all medicated, so he just doesn't, he feels the pain, but it doesn't bother him as much because he's on medications. This one is really interesting, and we actually have a patient that has this one, an Interlaminar Implant. Now, here, I'll let you read that up there for a second. What they do is you have the spine here, usually in the lumbar spine. They do a little U-shaped, which way is it shaped? So it's a U-shaped thing curving out this way, and it keeps the disc spaces open, and that's what it looks like. So see these little things up here? And so it's supposed to hold it open, and it looks really weird. They look kind of like those little paper clippy things from the front. And I asked him if you know, it felt good, and he said he didn't really notice a difference. But the thing that's bad about this, when you have that hardware in there, like I said, it restricts that motion, which they think is a good thing. So whenever he tries to extend his back and do that cobra exercise, he can't do it because it's stuck. And so, I mean, that's just, it's totally crazy land because it's just the opposite of what we believe. We believe you have to work with the body, you have to be moving, you have to have the nutrition, and they're just like, no, we're smarter than that. We're going to keep coming up with all these crazy things. There's one in a minute that you're going to just, I still can't believe it. They put sealant, and they used to literally just inject cement into where the disc was and think that that would be a good thing. And I just don't know in what world that's a good thing, because it starts to totally break down the bone, and it's just not, it's not good. So Johns Hopkins report, everybody always respects Johns Hopkins, great thing. Well, in the long run, for herniated disc, they decided that it's no better than, that surgery is no better than non-surgical treatment over the long term. So why go to the expense of having all this surgery, and there's a huge increase in the number of opioids you have to take for the pain, and why do that when you can just do the non-surgical approach? But the key is you have to stick to the schedule, because as we've told everybody in here that are patients, we move it a millimeter or two and it moves back half that after each adjustment. So if you miss an appointment, then that's going to kind of slow down your progress. So if you come multiple times in a day, which a lot of you guys do, which is awesome, and that's really going to get a lot of progress. And I personally, we just started doing that a few years ago, and I'm still shocked that we get such a great result, because I would think you needed to, you know, have a little more time to rest. But since the body goes on a 90-minute cycle, we'd recommend 2 hours in between each adjustment, and so that helps you make your progress even faster. This was something that Dr. Bergman and I were just amazed by. So whenever you have, all right, fusion here, fusion here. So what's going to happen if this isn't moving? This part, this section above and the section below are going to have to overcompensate, so they're going to get hypermobile, and they actually have a diagnosis code for that. It's called a transfer lesion. So once again, in Crazy Town, when you're doing something that leads to other problems that you have to make up a name for this problem that you've caused, how is that a good thing? I don't understand it. And so it can actually lead to a variety of other things, but the body is smart. The body's always smart, we know that. And if you get that fused section, it's going to make the other sections hypermobile to keep that range of motion. And sometimes it'll even form joints in between bones that aren't supposed to have joints. It's called a pseudoarthrosis. It's another mouthful. And it's just the craziest thing, because you see things that are like, what is that on the x-ray? And it's actually, it's trying to make a joint to stabilize the section, and it just doesn't make any sense to me. And along with the transfer lesion idea, this is another crazy one. They actually have a code for failed back surgery. So now, in chiropractic, you have a failed adjustment. You just might be a little sore, and then you come back, drink your water, and then you just get another adjustment, and then it gets better. Failed back surgery, you've got hardware in there, and there's no, oh, whoops, my bad, let me take that out. It's not how it works. So this is like using a permanent marker to change something, and you can't go back. And you have to be more proactive with your health and actually do the things that you need to do to be healthy in order for your body and your back to be good to you. Now, the scoliosis affects 5 to 7 million people in the United States. Now, normally, from the front, we know you should have it should be nice and straight. But if you have any kind of curve like this, a lateral deviation we call it, that if it's more than 10 degrees is considered a scoliosis. We have patients that have we have one that was a 60 degree curve. And so of course the geniuses there out in the medical world think, well, let's put a titanium rod in here that keeps it from bending further this way, and that'll just like keep them straight. And it just, we've got pictures of this too, you're just not even gonna believe it. And it just doesn't make sense to us, because what we do, as you know, is we'll sit there and we'll do a vibration through the concavity of the curve when a lot of people wonder what we're doing. So you'll be face down here, the curve is like this, we pass that vibration through here at 10 cycles a second, and what that does is it helps the disc, since it's a ligamentous material, it helps it to relax, and that changes the proprioceptive firings here. And then we also do the lateral deviation, so we flex the legs down and push on that convexity side, so that's actually allowing the body to start to perceive itself like it needs to be like this, instead of like this. And so that's how you work with the body to help reverse the scoliosis, and you don't start throwing hardware and stuff like that in there. That's just awful. So how we evaluate this, and we do this if you have any scoliosis, you'll know this when we took your x-ray. So if there's a bend like this, we take an x-ray so we can measure the angles, which is like this first case. So let's make it like it is in this. So this is almost 70 degrees. This is a patient of ours with a pretty severe scoliosis. But the crazy thing is too, the body is smart, like I said, and it has something called the righting reflex. So even though this looks horrible and you'd be like, oh my gosh, what does that person look like? When you see them, you couldn't tell that they have a scoliosis, because their body has adjusted in so many different ways and shifted. So when you look at them, they look like they're straight up and down. But it's just amazing. You see x-rays and you're just like, whoa. And what we do, measure that angle, and then we have them bend off to the side, and the amount of correction in that curve, so say right here it's 60 degrees, and then we have her bend. I want to see here, this is her bending, so you can see it goes from 60 all the way to 31.7. Now she still has the curve there, but this shows us that the minimum amount of improvement we can get with our protocols for correcting scoliosis, the minimum amount is 31 degrees. And there's no hardware, there's no risk of infection, there's none of that stuff. And this is actually her after her first 6 months of treatment. She went from 67.9, almost 70 degrees, to only 50 degrees. And those degrees are really hard because you really have to compare the same. We're measuring the bottom of the curve here because you see how it makes that little wedging here when you have the curve. And so you go from the bottom of the curve here to the top of the curve here. And so that's what we did here as well. And I mean, it just blows my mind that we show people this all the time, especially if, and that's the sad thing too with cases like this. Most of the time scoliosis patients are females, in the age 10 to 15 is when they notice it. And it's just really sad because you see people that come in like this and we're like, we can help you, and they just get all teary-eyed. They can't believe that we can do that much, and then we do the x-rays and they're just blown away because they're like, why don't more people know this? So that's why I wanted to talk about this before the holidays. Take care of your loved ones. I know back surgery is a scary topic, but there is hope. You just have to go to the right people. That's all it is. So this, I actually got this, fortunately, from the American Chiropractic Association. They said there's only 3 treatments for scoliosis. Careful observation, which is a total waste of time. I don't even know what that means. Bracing and surgery. Bracing has never been proven to actually work. Surgery, we've already talked about this, but they just don't know about just doing the simple bending film to see what you can do, changing the proprioceptive firings with the vibration and bending into the convexity of the curve. It is so, we have 99.999% success rate with scoliosis. I mean, every scoliosis patient we have improves to some degree. We have one patient that could not even go up the stairs. She had one of those little chairs she had to sit in to go up the stairs because she couldn't make it up the stairs. She had all kinds of digestive issues. I think her scoliosis, I think it was like 75. It was really intense. And she'd been in and out of the hospital, but now she's one of our biggest fans. She comes in all the time and I love her to death, and she doesn't need the little chair to go up the stairs anymore. It's crazy. So now prepare yourself. Here's some of the crazy hardware that the medical world tries to do to fix. So you can see the hooks on there. And so, I mean, this is so crazy. So this person has been off this way, and so they have these metal hooks literally that are just like hooked in there, and it goes all the way down. So that's a full picture of it. And so, I mean, what kind of mobility does this person have? And obviously you can see their digestion is awful right here. And I mean, they still have a curve down here because the body's trying to compensate. They're like, well, we can't move here, so we're just going to start moving more here. I mean, it's amazing. And then here's another one. There's at the lumbar spine. You can see even more. There's a curve there still, and then that part there. So now sciatica, that goes from the lumbar spine. The lower lumbar spine forms this nerve that's about as big as your thumb, index finger. It's actually really sturdy. If you in gross anatomy, you used to be able to pick up the cadavers by their sciatic nerves. They were so sturdy, because I always thought going into school nerves were like little teeny tiny things, but this thing is huge. And you know it too, because it feels like you've got fire going down the back of your legs. Some of you guys that have experienced this, it's not good. You can't sit down because that puts pressure on the disc, puts pressure on those nerves, and it just lights up your low back. So how we diagnose this is when we first have you come in, we do the exam, we have you laying down on the table, we do a couple of orthopedic exams, and one of those is when we raise your leg up like that and ask you if you have any pain in the low back when you're laying on your back. And so what that does is when you raise that leg up, it's actually stretching. So you're laying like this, we raise that leg up, and the nerve comes from here all the way down the leg, and so we raise the leg up, it's actually stretching that sciatic nerve, and if you have anything that's occupying the space here that shouldn't be, like we call it a space-occupying lesion or a herniated disc, it's going to put pressure on those nerves, and it's just going to send a shock wave down that leg. So that tells us, when an orthopedic test is positive, that tells us that the spinal cord's involved, and it's a lot more difficult to fix. So here, the treatment options. Chiropractic care actually has been known to really be good for sciatica, because it's just one of those things where, you know, what kind of surgery are you going to get? There's a muscle called the piriformis muscle, and a lot of people get confused by this one, because this right here is the sciatic notch where the nerve comes down through here. I don't want to get too technical, but then there's a muscle that goes right across from here to here. That's the piriformis muscle, and that actually can get really tight and put pressure on that nerve. And so they think, oh well, if they do like a release surgery and cut that muscle. And so they think, oh, that'll take the pressure off the nerve. There's so much cutting and stuff. Like, oh, it's pinched there, we'll just cut it. Well, then that's not the problem. It's tight because of the nerve. You got to take the pressure off the nerve, and then that'll relax the muscle, and then everything's going to be fine. But they just go in there with all their hardware and their knives and stuff and want to cut everything, which is sad. So basically, this is to make sure that you don't suffer from sciatica. You want to have a healthy diet, maintain your activity level, the healthy nutrition. You don't want to eat all the junk food and things like that. No Nabisco snack, things like that. Proper posture is really important. Good body biomechanics. So now this is crazy. So prepare for when you have sciatica, you go in and you want to get lumbar surgery. This is crazy. Now notice, he has fusion from here to here. He's had this whole, all the posterior elements, so this part has been taken out. So he has the rods, the screws going in here, but then he has some sort of cage in here to help like maintain that disc height, and then you see it from the front here. Now what's really scary is, we talked about this, the cement they put in your system sometimes to help stabilize the disc. It looks to me like it's leaked out to the side here, and so it's all down here in his abdominal cavity. We actually sent this to a radiology specialist that all he does is look at x-rays, and he had no idea what it was. He's like, I don't know what that is. It's an alien something, I don't know. I mean, it was scary. And this poor guy is just, what?
You don't have any bone in there with that tooth
No, just in the back part. You have the vertebra still here, but, well, you see a vertebra here because it has to screw into there and the vertebra up here, but in between these two, there's no bony structures in there. It's just that holding those apart. I mean, it's intense. And so here's that other lady that we had before with the artificial discs. She had sciatica as well. Now this is the saddest story of all. So this was a patient of ours years ago that came in, low back, doesn't look too bad. She had sciatica, because sometimes you can't see on x-ray if it, how bad it hurts, because you can be like, oh my gosh, the pressure, it hurts so bad, but on x-ray it doesn't look that bad. So everybody's different. But we had her come in to get adjustments, and at that time we were doing a trade with her because she didn't really have the money to pay for care, and so she worked at a fish market, I believe, and she would bring us fish, and so Dr. Bergman would be like, okay, we'll take care of you. And then it got to a point where she couldn't afford the gas to come down here to get treated. So she was just having to pay for gas to come down here, and she couldn't do it. And so she, once again, sciatica, it's not getting better because she couldn't keep her appointments, couldn't keep their regular adjustments like we're supposed to. And she went to another, got a second opinion, and the doctor said, oh, let's just fix it once and for all. Don't worry about all that chiropractic stuff. We'll just get it fixed. So this is her most recent x-ray. So, yeah. And the worst thing, still has sciatica. So now she has all this going on. I mean, thinks there's inflammation going on there. I mean, I can't believe it. And this is her from the side. So I know people when they're in pain. I've had people when I was playing football that would get really bad hamstring cramps and things like that, and they would just be screaming. They'd just be like, oh my gosh, just make it go away, take my scholarship, I don't care, just make it stop hurting, just make it stop hurting. And I mean, we laugh, but I mean, it's really sad because when you are in that much pain, you just want it fixed like that, and that's why opioids, things like that, because they go in there, if they don't get the treatment, they start taking all kinds of meds. They get the epidural shots, and that weakens the surrounding tissues. You can only get 3 a year, and it's not actually fixing the problem. It's just alleviating some of that inflammation, but it's not fixing the problem, and it's just so sad. So now we're going to talk about neck pain, just real quick. I know I'm going really fast. So whiplash, everybody that's been in a car accident or played football has had that whiplash and that can cause all kinds of soft tissue damage here, and that can cause a lot of inflammation and lasting numbness, tingling in the hands, waking up where you can't feel your arms and you're just like, yeah. And there's also some degenerative disorders that can cause it as well. They can cause arm numbness and things like that. The osteoarthritis, we talked about that. That's just arthritis, inflammation of the bone. Spinal stenosis, that can be either through the canal. So the canal is right through where this metal thing is. It goes all the way down through here, and that's where the yellow cord goes through. That's the canal. And there's a ligament on the inside of that can get overgrown, and so there's not as much space. So they call that stenosis. Or these little foramen, the nerve holes, get some thickness in there, so they get pinched off a little bit, and so that's also called stenosis. If you have that reverse curve in the neck, we see that sometimes in x-rays, especially in people that have scoliosis. So if you have a reverse curve there, it's the body's way of trying to correct the imbalances from side to side, so then they have that forward head carriage. Puts a lot of pressure on the brainstem here, causing stenosis as well, because it's stretching. It's like a rubber band and it's stretching it. So that causes a lot of problems. This is another one. And degenerative disc disease, of course, which is the arthritis that we see here in the office quite a bit, which is a progressive condition. But if you're getting the right type of care like we get here, you don't have to worry about it because it starts to reverse itself. But like I said, as long as you stay on your schedule, get your adjustments regularly and do your nutritional changes, drink your water, do your neck curve exercise, it's so important. And this is a patient. Now, chiropractors are going to freak out when they see this next x-ray. But the thing is, when you have fusion, you obviously can't adjust the sections that are fused because they're fused, but you can adjust sections that aren't fused. So, obviously this did not happen all at once. This individual came in, had the posterior surgery done, and then later on had the anterior surgery. So they go in through the muscles of the neck and the back here, fuse those, and then if there's still symptoms, they're like, okay, they move your throat and trachea out of the way and stick everything in there that way. The only bone she has that can move is right up there. And I actually got to do a kind of a residency internship type of thing at Whittier Presbyterian Spine Center. And when I was in there, I was working with a lady. She was a great lady, super smart. She went to Johns Hopkins Medical School. She went to Harvard undergrad, super smart lady. And she was really honest, which I appreciated. We were going in, and I got to sit in when she did her post-op consultations with her patients. And a gentleman came in, he was in his 80s probably. And she pulls up his x-rays, and I'm just sitting in the back just trying not to say anything. And I'm just like looking at that x-ray, and I'm like, that doesn't look good. That doesn't look right. But she was just kind of like, oh, everything's going great, because it'd been rough recovery for him, and he had just gotten to a point where he could get in and talk to her. And so what had happened, he had something similar to this, not quite this extensive, but you could see the screws right here had started to pull out. And so there was a gap right here. And so I was wondering if she was going to admit that she'd made a mistake. And she didn't really admit she made a mistake, but when we came out, she said, that's not going to be good. And I was like, why, what happened? And she said, well, there must have been an anomaly in the vertebrae, in the bone itself, that they didn't notice. And so the screws, it was like in bad soil when you're digging a hole or something, and so it just came loose. And she said, he's going to have another surgery. And I don't want to tell him that, because he's so happy that he's finally better enough to come in to get a consultation. And I was just like, eesh, that's going to be rough. And he was in his 80s. I was like, that's, ugh. And this is another one with the artificial discs. This is really crazy. So this is a patient of ours. She had neck fusion, and she just came in a few weeks ago and let us know that, oh, the doctors let her know that they had actually put the plate in backwards. And I was like, hey, did they not like see how did they do that? And she was like, I don't know, they just told me it was backwards. So any case like this, and a lot of times, look at this part here. See how it's curving this way? So this part is going backwards. I mean, yeah, it goes up here, which is good, but this part is reversed. So a lot of times we'll see people that get fusion in the neck, and they fuse it with a reverse curve. And I'm like, well, at least fix the curve if you're gonna, I mean, I don't get it. So for people, I won't mention any names, but if people haven't had surgery or considering getting surgery, just really stick to your schedule, stick to your adjusting appointments, get as many as you can in, do all your neck curve exercises. I'm not looking at you. And make sure that you're doing everything that we say, because we really do care about you, and we don't want you to do anything that's going to end up with you having to have surgeries and things like that might end up getting you hooked on different meds and things like that. It's just really something that you need to really try everything before you do that. Now this is a really cool story, but before I talk about that, that's my biggest point, and that's the Christmas hope after this talk, is that you really do. I know it's kind of like when you go to the gym, you make a New Year's resolution, you're like, I want to work out, I want to do something like that, and then you try it for like a time or two, and you're like, oh, this doesn't work, and then you don't do it. I'm begging you not to take that approach with your health as far as your spine goes. And if you really are on the borderline of contemplating any kind of surgery, really commit to at least 60 days. You're going to stick to your appointments, do all the nutritional changes, and really do the things that we suggest, because if you owe it to yourself to do that, to make sure that you've tried everything you can, so that if you do, for whatever reason, decide to go in and have some sort of surgery done, you feel like you've really done the best you can. And you haven't just come in here and there, but you actually have stuck to a schedule and tried to give your very best to get better. Okay, back to this. The miracle. This guy came in, he had a C6, C7 fusion, as you can see, and he had an artificial disc in there. That's what those little lines represent. So we started adjusting him. He had a 154 curve in the neck there. This was him later. He actually went back in and had his plate removed. And I was amazed that the surgeons would even do this. I'm like, I would think, well, it's too risky. So they went in, had the plate removed, and he's fine. Well, he adjusts his neck, works great. He gets some numbness, tingling every now and then. But I was really impressed by that. So yeah, he's one of the only 2 people in the office that have ever had that done. I was really impressed. So now we're going to talk about workers with back injuries real briefly. So this is just a common sense thing. If you have a back injury and you're a worker, if you go to a doctor or surgeon first, there's a 42.7% chance you're going to have surgery. But if you go to a chiropractor first, then there's only a 1.5% chance you're going to end up with surgery, because at that point you want to get back to work, you've got bills to pay, and if you're doing the non-invasive chiropractic approach, then you actually do get better, get back to work faster, and there's another study I'm going to talk about in just a second. But then if you're going into surgery because you went to a surgeon and you're trusting them, your work usually sends you to a particular workers' comp type doctor, and you go in for surgery, you're talking months, if not years, of time from recovery and can't work, and it's just a road you don't want to go down. So now this is from the Division of Epidemiology and Biostatistics, Department of Environmental Health, University of Cincinnati College of Medicine. That's a mouthful too. So they had 1,450 people. They took half of them, they both had the same symptoms. Half of them had surgery, half of them did not have surgery. This is a crazy study. After 2 years, only 26% of those who had surgery were able actually to return to work, while 67% of the ones that did not have surgery returned to work. So, I'm like, that's crazy. I'm like, okay, so 26% had surgery because they went down that road and they got on the meds and they just were like, oh, and it's the mentality. And that's the sad thing too. If you've had surgery, you don't want to be wrong. You don't want to admit that you made a mistake because you've already got it in there. So it makes you feel kind of foolish. So it's crazy. So 26% returned to work that had surgery, 67% returned that didn't have surgery. So that ends up being a 74% failure rate. Now when you go in, there's 90% failure rates reported, there's 33% failure rates reported. It's just the whole idea of take care of yourself so that you don't have to worry about any of these failure rates or anything, and just don't do it. And this also suggests that there's a 257% better chance of returning to work if you don't have surgery in the first place. So that's what we need to focus on. And then this is the sad part. 41% increase in the use of painkillers, particularly opiates, in those that had the back surgery. So you're in pain already because you have sciatica, you've got neck pain, you're in pain already, so they're like, all right, take this, and then we're gonna have surgery, okay, take a little more of this. And then you just get to a point where, yeah, you might feel your pain, but you just don't care about it anymore because you're high all the time. And that's not good. It causes a whole nother, it stops your whole digestive tract, and it's just an awful way to go. And this actually is from the CDC. 44 people a day die from prescription opioid overdoses. Now, obviously, they're not all from surgery, but it's just one of those things. And even with football, there's a lot of guys that I know that can't even get out of bed without all kinds of pulley systems and stuff like that because their knees are bad, back's bad, and all that stuff. And I mean, they're taking all kinds of pain pills, and it's no way to live because you're just kind of living in a haze. You're like sleepwalking through life, and it's just no way to live. Okay, so here are the takeaways. Please exhaust all conservative options first and stick to the schedule. Don't say, oh, I went to the chiropractor twice and he was no good, he hurt me, blah, blah. Find a chiropractor. If you're out there in YouTube land, find a good corrective chiropractor in your area. We have a list of 7 questions to help you find one. Come here if you can. We welcome people to California, so feel free to come in. And it's one of those things you really owe it to yourself to take care of yourself and do the conservative approach first. Make the lifestyle changes. I know that's hard because people like their ice cream or they like their watching soap operas and eating caramel corn all day long or whatever. But just cut back a little bit just to gradually replace the bad stuff with good stuff. So instead of caramel corn, have kale chips. Or something like that. Instead of having a soda, have some alkaline water or something like that. Anything to kind of balance it out. You have to replace a bad thing with a good thing, because if you're not, then you're just going to go back to the bad thing. Make your dietary changes. Like I said, find a corrective chiropractor. And remember, 257% better chance of returning to work in that study if you avoid surgery, if you want to work. Hopefully, not all of us have to, but it's a part of life. So that is it. Do you have any questions?
If somebody has already gone in and had surgery because they had sciatica and they did, it probably didn't correct their problem.
Right.
So how soon after they do a surgery would you recommend or try to convince them to go get chiropractic care?
As soon as possible.
Oh, okay.
Yeah. Yes.
How else do you treat a herniated disc exactly other than having surgery? You didn't mention that.
Oh, I like that. That's an excellent question. When you have a herniated disc, it's bulging out here, putting pressure on the nerve because these bones are misaligned. And when they're misaligned, that is the subluxation. It starts to put pressure on the disc. It starts to deteriorate. So when we do the adjustments, we're realigning those bones. That's going to take pressure off the joint and off the disc. And so, because the disc is a very structured, ligamentous, layers and layers and layers of different ligaments going in every different kind of way. So it's a really strong substance. And so we realign those bones. That's going to make the disc line up better, take the bulge away. And when we do that flexion or the cobra exercise, it pulls the bulging part back into the section it needs to be in. So that's the solution. You don't want to cut anything out. I mean, I know it's kind of like, oh, I got a splinter in my foot, let me take it out. No, you just do this, because you can't take something out without having a negative effect. So it's just the flexion and me jumping off the top rope and hitting you in the low back and getting that opened up for you in particular.
One of the things that I find with people I know is that they'll say, well, my insurance won't cover chiropractic, but it'll cover the orthopedic surgery.
Right. And that's the scary thing, is because they don't value themselves enough in their health, and they're just like, oh, well, I can't afford to pay for it. When we have the care credit, we have ways of helping out and making it affordable, and you owe it to yourself so much, you and all your loved ones that you want to be around for and functional for, that you just do all the non-invasive approaches first.